set it to 0, something of that sort. So depending on my interest, I mean the research or whatever the clinical experts want to analyze, we would be setting the window. And then now, since the visualization is clear, we can further process the way we usually do on typical imaging. So different kind of pre-processing we do on the imaging are, we try to highlight the features, right? So we may go with increasing the sharpness or the contrast or the brightness, something of that sort. Or sometimes we may need to resize. These are certain kind of transformation we typically apply. Then uh, we need to reduce the data set. So that's also one of the pre-processing tasks. So we may need to register the data. Registration is one of the pre-processing thing. So there are several, I mean, now what are the pre-processing steps I'm listing? Those are not different than that of your typical image processing steps. Those are same. I mean, we have used these steps for the image processing. So similar steps we can follow for this analysis as well, like pre-processing. Yeah, this is another kind of modality is X-ray radiography, which helps to identify the bone fracture, certain tumors or abnormal masses, pneumonia, something of that sort. Okay, so you can clearly visualize the bones and then uh, in any kind of abnormalities or fractures as such. Mammography, mammograph, again another kind of X-rays. Again, we can see some kind of abnormalities. Then there is in dentistry there is a panoramic images available. Okay, so uh, uh, those are referred as PX, panoramic view of the entire mouth, which helps to identify the dental tumors or tooth eruptions or any kind of surgical decisions to be taken or implant to be done. So based on, looking at this panoramic view, the experts can decide on the treatment, can identify the tumors, any kind of bone loss. So it helps to, and I mean these are the different applications we can use this dental data for analysis. Of course, the MRI images we know mainly used for the brain analysis, but can be used for the tumor cord, kidney, liver, uterus. Okay, so it's another kind of imaging. Again, to focus on the brain, there is a positron emission tomography, PET scan for tumor or the heart diseases or brain disorder. Then for eyes, there is a fundus imaging, which is used to identify any vascular disorder. This you could see the microvessels from your eye. Okay, so any iris related task or vascular disorders or glaucoma or some kind of eye anomalies, it can be detected. So the fundus imaging is there. Then there's a optical coherence tomography again for eyes, which gives you the cross section view of the retina. Okay, which is used typically to identify the glaucoma in diabetes patient. Then we can also identify the damage to the retina, then macular degeneration, macular holes. So the different kinds of anomalies we can identify with this OCT as well. Then comes your, so uh, histopathology images also been considered as a biomedical imaging because uh, histopathology images are basically the we heard about the biopsies, right? So when the biopsy has been done, that portion of your tissues are been given to the laboratory for further analysis, and then usually we trust whatever the lab result says rather than the user symptoms, or based on that what the doctor concludes. The reliance is always on the results provided by the histopathology reports. So we usually consider the histopathology report as a ground truth for this imaging analysis, so because it is something being analyzed in the laboratory. So yeah, so these are the, I mean, again, another kind of imaging. to detect the cancer or various kind of infections. So this typical images you can see is of the intestinal glands, where you can see the crypts and then this villi structure, the long one, nuclei, and different components of. And then yeah, there are videos can be generated with the help of endoscopy. Now the endoscopy can be done of different organs. So this is again typically for the bowel diseases, inflammatory bowel diseases. So for the intestine again can be helped to identify the ulcerative colitis or some chronic diseases, maybe the stomach ulcers, tumors, or another digestive tract infection. But then these are the videos. So of course the pre-processing involved here is from the videos we extract the frames and then we process the frames further. Okay, so depending on what kind of data you have, we do the pre-processing. So yeah, so using the medical data for analysis. So before we just move towards biomedical imaging analysis, I tried listing different data sources over here, which comes under the healthcare domain. And why I'm listing here, because we may use these different sources together to improve on our accuracy. So basically these different data sources in the healthcare domain can be classified as a clinical data or omics data or the patient generated data or the administration or operational data, public health or unstructured and alternative data or emerging sources, depending on the source of generation of that data. Like clinical data typically generated with the clinical direct clinical interaction, like hospital information system, then all the clinical trials and research studies, then radiology and imaging data that comes under the clinical data. And yeah, one important thing, like this, the nature of data for this again as usual falls in different categories. Like it can be the structured or semi-structured or unstructured, like hospital information. All different kinds of information systems are typically the which comes under the structured data, right? Then radiology imaging is something unstructured. Then your social media videos or voice recording, all those are unstructured. There are some reports like manually written reports by doctor or by patient, because patient also writes its own um, uh, reports, right? Right. I mean, the conditions, whatever, say monthly or weekly, depending on the performance. I mean, the medicine, how it, I mean, helps to heal or not, depending on that. So that data have been captured from the patient. So it's in semi-structured format. So omics data is also there, like genomics, proteomics, So basically, these are the DNA sequencing or protein expression data. Protein expression data typically used for the drug discovery. So, I mean, a variety of data have been generated, and we can integrate this different kind of data to improve our accuracy. So, not necessarily will be just including the imaging. Along with that, probably we may take the data from the patient, which describes the symptoms, or from the expert, clinical expert, which describes the symptoms of the patient, and then we may consider the laboratory data, okay, which gives the details about the blood test or pathology reports. So that kind of information we group together and then we analyze it. So that kind of analysis, we say it's different kind of fusions, like data fusion or decision fusion, two different categories we use generally in the AI. So yeah, the another let me just, I mean, this fusion, these techniques, as I said that this different kind of data we may need to fuse in order to improve on our accuracy. So that is a data fusion. So data fusion again we can do at like different imaging modalities also we can fuse together to improve on accuracy, or we may fuse the textual data like the lab reports along with the imaging plus the uh, doctor's interpretation. So that also will come. So merging all these string together will definitely improve the accuracy. So that's a data fusion. So we make our data robust before we provide it to the AI model to analyze. So that's a data fusion. And then decision fusion is something we are integrating multiple AI models to generate the final results. So, I mean, 4 or 5 different models we kind of ensemble learning is a decision fusion. Ensemble learning is an example of decision fusion where we integrate multiple AI model. So, so these different kinds of fusion we usually do while analyzing this data, medical data. I mean, it's actually basically applicable to any of the AI tasks you use for. Okay, so yeah, and then the important thing is metadata for medical images. We must consider, like we as we have seen that there are the DICOM images. It can be a TIFF image, it can be JPEG, or it can be the video file, it can be MP4, or maybe a different kind of video. Okay, so identify your type of data, what different modalities, what is the resolution, how many number of images you have. Then if there is a imaging, typically for the sake of segmentation or just say for example identifying the tumors or the infected area, we do a kind of segmenting the image. So uh, we may require some kind of annotations. So annotations we can do with the help of say a kind of putting the border around the region, or maybe just drawing the line to cover that specific. So there are various ways of annotating the data. So here again, we used to take the input from the clinical experts before we actually do the annotations. We try to collect the annotations from them, a few images they should annote. So because we are not a domain expert, we know nothing about that domain. But then yes, the expert must help us to come up with the annotation part, like this is what is the benign tumor and this is the uh, unharmful, something of that sort. So this kind of details, I mean, so expert interaction is very much essential whenever we do any kind of this medical data analysis. Then ground truth is also important. So ground truth is again can be the expert's opinion, maybe multiple experts saying the same thing, or whatever the laboratory result, like the histopathology or biopsy report, what the biopsy report says, that is also been considered as a ground truth. Then associated data, maybe as there is some other data we should also consider, like demography, clinical data, or a laboratory, as I said, genomic, timeline, social media. Maybe in the case of pandemic, we're supposed to be considering what the world says. So sometimes some of the posts might be useful to um, do some kind of analysis related to, say, for example, during the COVID period, a lot of analysis has been done, lot of data from the social media being collected and analyzed. So yeah, so but then these are very important factors like demographically. I'll give one example how much impact it has on the analysis. Then yeah, of course, like this medical data is really very complex because it's multidimensional. Even if you say CT scan, you could see that for one patient the data may take depending on how much has been captured for each patient, but then it has a capability to go for till 1 or 2 GB for one patient. So that kind of, even the videos, depending on for how long, for how much period the video has been recorded for endoscopy. So but then you know that for 1 second might be capturing multiple frames. So it's not one video for us, there are several, maybe 15,000, 20,000 frames we need to process for one patient, something of that sort. So yeah, so it's a lot of complexity is involved in this medical data, multidimensional, multimodal, multitemporal, because for patient we know that it's not a one visit, right? There are multiple visits. Then and every visit typically the clinician tries to understand the progress or any kind of remission happening after the treatment. So to evaluate that, there are repeated tests, again analyzing that as well along with the time. So basically, I mean, it's eventually a huge amount of data you need to analyze, and uh, being a researcher, sometimes to set a fundamental model, probably we should, because uh, the considering the data from one hospital, only from one center, uh, will not be sufficient, because then it can be said that it's not a generalized model. So to make it generalized, you may need to collect the data from multiple centers. So when you collect the data from multiple centers, then there are multiple devices which are capturing the data. Again, you need to put your efforts to standardize the data and all. So a lot of kind of I mean medical, you can say, things we need to take care, uh, and that's why I mean it's a quite complex thing, but yeah, I mean it's not difficult, though it involves a lot many processes, but of course, I mean a lot of work has been currently going on in UK based on this, uh, in the medical domain. Yeah. So here will come about, I mean, as I said, that there are some kind of aspects we need to take care. So like demography, and so here it's talk about the the important factors which influences the result of your medical analysis. For example, the race or centricity, like basically the demography, the age, and then the gender. Okay, so the one analysis already, I mean, the research work has been published, that how these things are impacting the results. The analysis is about the fetus, different parameters been captured for the fetus from different regions, from the Asian or from the white ethnicity, from the UK or Europe, and then Asians like Japan, China, India, and so on. So what has been observed, like I mean, what the usually the model has been designed studying that the measurement of fetus size is to determine whether the growing is going well or as per the standard baseline or not. So what the model suggested, the model's outcome was that healthy babies with a non-white ancestry are much more likely to be identified as developing the abnormality. Okay, so like the healthy babies with non-white, I mean, like we, as we can take like the Asian peoples, basically non-white is, and and then developing the abnormality while with their smaller bones among the Asian population. Okay, that's what the model outcome. But then study demonstrated that this, and we also know logically we can think like, because we are not, I mean, it's the Asians are typically shorter than the Europeans and then UK or Americans. So and this will definitely impact the fetus height as well. So they just try to prove this thing, like how these things are analyzing. It has been observed that the fetus has been declared as abnormal, but then after delivery, apparently it is observed that all those studies where it was declaring that it's abnormal, all those fetuses were appeared as a normal after delivery, and there is no malformation or suspected genetic syndromes observed for those babies. Okay, so it's I mean, these are some of the things, like the race or the age. Age also matters a lot. The gender also matters a lot, right? I mean, so these are some of the aspects which we should consider while analyzing the medical data. Okay, so Yeah, so medical data analysis, typically what we do is we do the diagnostic analysis or a prognostic or the therapeutic analysis. Like diagnostic is what? Diagnostic is just to diagnose like whether the disease is there or not. Okay, to detect or confirm the presence of the disease, it is there or not. Prognostic is like it will provide you the likely outcome of the disease regardless of the treatment. But when we use the therapeutic analysis, it is something where you trying to work with the treatment. Like you will check whether the medicine or the treatment given to the patient is effective, safe, or suitable. So it is, I mean, therapeutic analysis something related to the drug development or the personalized medicine. So whenever the therapy comes into picture, the patient and treatment comes into picture, there is a therapeutic analysis. Okay. So yeah, so the trending AI advances, the generative AI, or here I would be covering the generative adversarial networks because those are used widely in the medical data analysis. So different kinds of uh, this adversarial network like GANs, like generative adversarial network. Again, typically we classify depending on uh, on which I mean what principle been used to design that particular GAN model. For example, if it has been developed based on certain condition, there is a conditional generative adversarial. We put certain condition on some parameters, like this parameter should be having, say, maybe if I am interested in the tumors, maybe I would say that this particular region should not be beyond of this size, maybe in terms of pixels or calculating the length, something of that sort. So putting the conditions, then if there is a change in the objective function, for example, if I'm using the least square generative, so depending least square generative functions, like our error calculation, basically that's the objective function we say. So depending on what function you use, there are again different categories of GAN developed by different researchers. Then based on the architecture, we have the bidirectional generative adversarial network, which is using the latent space. Then there are architectural variations like cycle GAN is there. Then SAGAN based on the self attention generative adversarial, pix to pix, depending on whether, I mean, it's again variation depending on whether you will require the pair to generate or without giving any kind of pairing, you can generate the data. So different kinds of GAN models are being used in the biomedical imaging. Now, these models are being used for several different tasks. So here just one snap I taken it from one of the research work where the different models like cycle GAN, you can see in the legend the cycle GANs, conditional GAN, pix to pix, AC GAN, DC GAN, LS. So different kinds of GAN and for what purpose it has been used. Okay, so cross modality generation. So I mean generating one modality from another, like generating the CT scan from the MRI scan. That's an example of cross modality. So cross modality generation is one application. Then segmentation, for image segmentation also these GAN models are being used in medical domain. Augmentation, if you have to augment the data, need to improve the data, to add on, to increase the size of the data, the GANs, different kind of GANs are used. Then for the classification purpose, of course, it can be used for the classification purpose. Okay, for the registration as well. Registration purpose also, the GAN models are used. For reconstruction, like I mean, regenerating the data, medical data. So doing some kind of eliminating the anomalies and reconstructing, or eliminating the noise and reconstructing. So different kind of, so you would see here that Some of the tasks are pre-processing tasks, like segmentation is a pre-processing, augmentation pre-processing, registration pre-processing. Then, you could even identify which are not relevant. So reduction, reduction is typically is a pre-processing thing. We need to reduce the dimensions because processing this entire data is not that feasible. Okay, you may not have the resources to process the data. You have seen as I was discussing earlier, that a huge volume of data is involved in this analysis. So we need to we need to use the high performance computing power to process this data. So typically for AI models, we use the GPUs, the NVIDIA GPUs, graphical processing unit. So this is we use basically the GPUs as a high performance computing platform to analyze the data because of that high volume. Then again, there are complex algorithms available. These GAN models, it's a lot of time it takes to process because it is, all different GANs with bit variation. There are multiple encoder decoder involved in this. So it becomes complex. The training takes huge amount of time. Okay. So we usually train these models on the high performance computing platform. Okay, so coming back to the different kinds of applications of this AI in the medical data analysis. So cross-modality image synthesis, like converting say 2D X-rays to 3D CT scan, MRI to CT, CT to MRI. Okay, here I'll just show you this application, cross-modality. Again, there are different variations like intermodality and intramodality. For example, if you just in CT, if you just capture the axial view and then you need to generate the front view or corneal view and sagittal view, then probably you would be using the existing data. So that would be the intramodality conversion. So from the same modality, if you are converting one kind of image to another, that's a intra. And then intermodality is totally in a different domain, like MRI to CT scan. Okay, then CT scan to MRI. So this is what is the MRI image you could see at the left hand side, and the proposed CT scan of that, generated CT scan out of that MRI. Then out of CT you can also generate the MRI. From CT you can generate the PET, and then from PET you can also, this is the work is already been done for generating the different modalities using this generative AI. I forgot to add the reference here, but yeah, I have listed it at the end. So yeah, the another cross modality image synthesis, like from the 2D X-rays generating the 3D CT scan. So you can have that real view is just the original images been given from the X-ray, and then the input views are the generated images by the GAN model, and then using those generated X-ray images, because then it generates a variety of different other images, and out of that those generated images, you can see that 3D view has been created. So that's a 3D visualization of the CT scan. And of course you can generate and at the end you could see that X-ray to CT scan, it's generating your axial views of the CT scan. Okay, so we know that the CT scan, the machines, the scanners are quite costly. So the X-ray are relatively cheaper. But so what if the laboratory has the X-ray systems and not CT scan? Then probably this development would help to generate the CT scan data, right? So it would be cost effective, and then in the rural area, these kind of mechanisms would be really very helpful. Okay, then yeah, medical imaging reconstruction. The example I will give is of LDCT, which is the low dose CT, because CT scan is, it has its own side effect, because the kind of bandwidth, the frequency, the kind of rays it passes through your body, those are also harmful. So why not you reduce the dose, I mean low dose CT scan. Okay, but then if you go with the low dose, you will lose the you can say the I would say the quality of the image. Like here, the the first row is, sorry, the first column is showing the LDCT, that is low dose CT scan images, and then after applying the GAN model, the next column you see that the quality of image has been improved. Okay, so this is what is the image reconstruction. When we denoise the acquisition, I mean, because we try to capture with the low dose, but then we try to give the same kind of resolution, same kind of quality as that of the high dose. So then we can do such kind of pre-processing and improve the quality of the image. So this is also kind of pre-processing, we could say. Then the another issue we observe in the medical domain is the data is not really readily available for the researchers to work on that. Okay, I mean it's because we cannot use the data as is. We need to take the consent from the patient. So it's not we researcher, but then the hospital system should have that kind of protocols, that they should take the consent, and after consent they should have their ethical committee which will approve the use of those data sources like biomedical imaging to the researchers. So if those kind of setups are not there, then it becomes difficult for the hospital also to share the data. Okay, I mean it comes under some kind of our policies like privacy policies. So it's not then easily available. But then with the help of GAN, we can generate the synthetic data from the real data. And then that synthetic data, since it doesn't belong to any of the patient, that can be availed to the public. So this is what is again another important contribution to the research work with the help of AI, where the data is being shared uh, uh, with the public, which is synthetic data, but which is generated from the real data. Okay. So you can see the segmented and then fundus image of the original and then the synthetic one. Okay, this is kind of just a workflow I just captured from that research work, where the real data set of the segmented masks has been given as an input, and then the generator will generate the synthetic images of the segmented mask, then giving those segmented mask as an input, and then the pair of fundy and then segmented image as an input to the generator, the GAN model. It generates the synthetic pair of the fundus and then its segmented one. And now on this data set, the researcher can work. Okay. So now this is one of the mechanism availing the data publicly to the users. Okay, then I mean, as I was telling earlier, that we can always integrate the different kind of data. So in one of the research work, it has been suggested that the idea is to, I mean, integrating the different kind of modalities like X-ray, CT scan, MRIs, and then the again different kinds of inputs, textual information, basically the reports and all that. You can generate a sample report. For example, for radiology, you can say that what kind of indications the modalities or the reports are stating, the fever and the cough. What are the findings? So maybe the lungs are clear without focal infiltration, something. What are the impression, the tags? So different kinds of, in whatever the requirement of the clinical experts. So for them, we can generate the such kind of sample reports based on whatever the inputs we have available with us. So for the different kind of medical domains like radiology, cardiology, dermatology, pathology, different gastroenterology. So for each of these, depending on whatever the task you're interested in, what different kind of modalities or input is available with the user, what kind of mm, uh, results or the reports to be generated, of course with the help of with the discussion with the domain experts, these kind of reports can be designed. So integrating multiple different models, so that's why we call it as a multimodal analysis, uh, where we try to integrate the textual and medical data, biomedical imaging together to come up with this comprehensive report. This is what this research work is suggesting. So, yeah, a lot of opportunities to work in this line. Okay, so I'll just explain you the case study on which I have worked, where we have used the cycle GAN model. So, yeah, it's the work is again the intramodality switching model, where the endoscopy videos are being given as an input, and then we extracted the frames out of those modalities videos, and then applied our typical convolutional neural network to categorize, because there are different kinds of modalities in the endoscopy as well, like iScan 1, iScan, depending on the device which is used to capture the information. So for example, just skipping it just to give you the idea about what different modalities are there. For example, in endoscopy there is a white light, the first one, the white light endoscopy. Then there's a iScan 2 endoscopy, iScan 3 endoscopy, iScan. So different modalities are there, and each modality tries to identify different kind of features. Some focusing on the kind of texture, some focuses on the uh, kind of the uh, inflammations which are there. Different kinds of inflammation which highlights the different kind of inflammation, or some tries to identify the kind of tumors or kind of bulbs in the video. So each one tries to come up with different set of characteristics. Okay, so uh, providing that kind of images, the first step is to identify which of the modalities has been provided as an input, and then applying the cycle GAN. So we have used the cycle GAN as the generator. Okay, and then we have generated the missing modalities. For example, if the white light is been given as an input, then it generates the iScan 2 and then iScan 3 out of that. Okay, so you can see at the column heading, like provide input column, then what is the detected modality of that input. That's a white light has been detected. So out of this white light, what is been generated is the iScan 2 modality and then iScan 3 modality. So you can say, some kind of red patch is there in the first image, and how prominently it is appearing with with different features in iScan 2 and iScan 3. Okay, so this is how the generators, or you can say the cycle, can help us to generate the modality which has not been existing. So the another one, like, which is provided with the iScan 2 as an input, generating the white light, and then iScan 3. Then iScan 3 as an input and generating the white light and iScan 2. Like that way. See, by chance we were having all the modalities, but then wherever now the model is trained, we can run the model on any of the data and can generate the white light iScan 2 and iScan 3. This is another example, the generated modality for white light, iScan 2 and iScan 3. The same data, same thing, only you could see the change in the color, the change in the texture, something of that sort. Okay, so it tries to give some details. Each of this modality is trying to highlight different kinds of features from the image. So what if we could avail this kind of mechanism as well uh, to the experts, so that at once they could see all the different modalities and they could identify the different kind of I can say different kind of characteristics and take their decision. So I mean it just to support the clinicians to take better decision. Okay. So yeah, the another thing. Okay, yeah, this I had taken just to explain, like as I said earlier, that we integrate multiple models together, right? The decision fusion. So this is an example of a decision fusion. Okay, where the cycle again has generated different modalities, but then the different modalities been given as an input to the pre-trained ResNet model, ResNet 50. It's widely used model in any of the field. Basically, it's very excellent model, ResNet 50. So we use the pre-trained model. So again, we are saving a lot of on our training time. It's a pre-trained model, and then uh, we just take the input of each of results of each of these model, what each of these models said individually. So it's basically the ensembled voting. So three different classifiers are grouped together to come up with the decision whether there is inflammation or remission. Since there are only three models here, so I mean the majority always wins. But what if there are four models? uh, so I mean even number of models, then probably we can put certain threshold that how much of these are agreeing above 70. If only three are agreeing, that's fine, or two are agreeing and two saying no, then again which probability is high, so we can consider the probability values to break the tie and can decide whether it's inflammation or the remission. Okay, so these are the results, like unimodal. I mean, considering only white light, how much is accuracy? Again, like when we process the medical data, we always, the medical people, they I mean, journals and all, they always talk in terms of sensitivity and specificity. Sensitivity is nothing but recall. I mean, we refer it as a recall, but then in medical domain, we have to refer it as a sensitivity. Then there is a positive prediction values, negative prediction values. The same thing. I mean, whatever we calculate in the confusion matrix, true, false, true, true. I mean, like that. Referring the confusion matrix, all these different parameters are been calculated. So for unimodal is been calculated for white lie, I-scan 2, I-scan 3, and then for multimodal also. Uh, the integration of all the multimodal is, I mean, considering the multiple modalities and then ensembled, of course, you could see the specificity is quite high. Even the accuracy is quite better, like 89, it's quite high if you integrate multiple modalities together. Okay, so yes, I mean, it really improves on accuracy if you just, I mean, trying on multiple or try to add multiple uh, in different kind of information in your analysis. Okay, so yeah, this is an example of your decision fusion. Okay, okay. So now the again the important thing we need to consider the challenges which are there in this advanced AI techniques. For example, the class leakage. Because we generate the synthetic data from the real one. Okay, but then probably we are, I mean, generating both the data sets from considering I mean the characteristics of real one, and then uh, uh, we are also considering, I mean while the raw data we are not much bother about the different classes, right? So which class, so we generate the images, but then it may possible that the synthetic images may have some of the properties from one class and some of the properties from another class. So there is a class leakage issue, a lot of scope to improve on this class leakage. Then evaluation. Traditional metrics we use at the mean absolute error or peak signal to noise ratio or some structural similarity. But then um, we need to also consider some kind of geometric attributes as well. Sometimes we, like if it's a tumor, then size of the tumor, really whether it's a tumor or some other, if we are considering geometric characteristics, then we need to consider the geometric parameters as well. uh, we need to calculate the geometric parameters to for the sake of evaluation. Then yeah, when we generate the data, probably generating is will not be preserving the small abnormalities, so we may miss on that kind of data. That those are something related to the AI domain specific challenges. And then for medical domain specific, again, um, like as I said that always this medical field they expect the generalized solution. Okay, but generalized solution, as even the example which we have seen, we say that generalized solution, but then for that fetus abnormality detection. Okay, but then can we really make it as a generalized one? Because it depends on the uh, geography. It very much depends on the geography. So probably there would be different set of models for that particular area or region, something of that sort. So uh, probably, I mean, for at least for that region, we should be collecting the data from multiple hospital to make it more robust and generalized. Yeah, so that can be done from our end. So so somewhere we need to identify the proper, or I can say the optimal solution to come up with this AI results. Again, the medical data is been captured with some, I mean, different, again, as I said, hospital, different equipments they are using. There are no, there is no standard setting as such. I mean, depending on the expert's opinion, there might be some setting, the parameters which will help to identify. I mean, you may consider is some textual parameter like what temperature has been said or what frequency. I mean, depending on what the information is being captured. So that should be uniform. So there are some issues at that end as well while capturing the information itself. There are some non-standard setting. So in uniformity should appear at that end as well. Then I mean the diseases, there are variety of diseases. uh, some kind of radiology ontology is defining around 12,878 different symptoms for certain. So I mean a lot of variations are there. I mean if we think of generating one robust solution, I mean ideally we should consider all that, but then yeah, it's not possible. So at least when whatever been observed, whatever has been there already known with the experts. So experts, I mean, as we are just a researcher, we know nothing about this disease and all that. So we need to always, I mean, consult the clinicians uh, for that. I mean, how much we can collect. Are there any other sources which will add the information which and helpful for the AI analysis? Okay. So again, the labels. Again, we one important thing is sometimes the medical expert also has the different opinion. So that is also a concern. So because that labeling we are talking about for the medical images, uh, that is also varies because sometimes we take the expert. I mean, it's not sometimes, always the initial consultation must happen with the experts to label the data. If they have the label data available first place, that's great. Otherwise, if they are giving, but then the expert also has their I mean, their opinion may differ. So that is also thing. Um, Again, medical data. Another concern is the samples are imbalanced because we know that usually the positive cases are quite less as compared to the normal cases. So then again there is an imbalance of data. Some of the imbalance we can always handle at our development level by balancing the classes. We calculate the weights again for the imbalance and then just add on those weights. So that thing we could do at our end as a developer, but then Yeah, I mean, that is also a major concern. That imbalance, handling that imbalance is important. Okay. And as I said, that complexity is always there, and we are striving to combine the different kinds of modalities, imaging and textual, all together. Uh, we may consider, I mean, different kind of clinical descriptors like blood tests, genomic information, medications, some ECG kind of results, or that kind of data. So then, I mean, it's really become very complex, and then you have to have the high performance computing power to train the model. Okay, and then this all together. I mean, I was saying that hospitals should. I mean, we should be able to capture the data across multiple hospitals. But then again, there should be a standard infrastructure should be there. Like in United Kingdom, UK, there is a NHS system. Um, so similar kind of uniform system should be there, which will where the patient data would be uniform across. I mean, or the same database they are updating for each of the patient. So you will get all the information at one place. At our end, what happens for different hospitals, we need to carry different files. So that is also, I mean, a lot of possibility of development as there through standardize or building this complex infrastructure and all. So in terms of, we can think in terms of imaging, maybe how we can. So yeah, of course, there are federated um, uh, systems available for this machine learning and all that. That also helps a lot. Okay. Okay, so yeah, so these are the challenges, but we can always take it as opportunity and a lot of scope for the further development to this. Yeah, these are some of the key references I have used. Okay. Okay, so yeah, that's it from my end. Thank you. So if you have any questions, I'm happy to answer. Yeah. Yes. Is there any question?
Partic- Participants, you can unmute and you can ask questions, or you can type in the chat box.
How GAN models are operated? It's basically it's the operated in the sense like we give some kind of as the example which I had given, like providing one modality as an input and generating another modality. So to that GAN model, cycle GAN is it's a readily available model. It's not been developed by me, so it's there already. So I have used that model. Okay, and then yeah, of course we need to do some kind of fine tunings to make it suitable for our data. Okay, so we make some changes in the model itself, but then no architectural changes. The number of layers, the pooling, everything will remain same. The way it calculates the error. Yeah, one more change I tried doing, because we need to maintain the identity of the image. Okay, we cannot hamper the identity. So we have calculated three different kind of error. One is the way usually we do, there is a generator and then there is a discriminator. So we calculate the error at generator level, discriminator level. Okay, so that's the entire model performance we do, and along with that we have also calculated the identity evaluation, identity error. Okay, so that there should not be any change in the identity. Okay, so that's why whatever the you could see the same patch appearing everywhere, because we ensured that it should not hamper the identity. Okay, so providing the images as input, running your program, the model to it, and then you just says we will mention that where you would like to store the generated output. So you will save your generated files and some other folder. That's how we work on the GAN model. Yeah, so how accurate are the conversion is like we have evaluated from with, I mean, how we have evaluated the performance of this generation, that we have shared the, the actual image and then corresponding generated image of around 100 or 150 such slides with the expert, three different experts, and then we observed that around 55% of their, I mean, integrating all their three results, we what we observed, like they are 55% they are able to detect which are the original. So 45% they are not even able to detect that these are the generated images. So that's how we are evaluated the performance. I mean, there are some of the things which, like if you see the images carefully, the generated one, so there are some kind of borders which across the borders of the image, sometimes it reflects that some lines comes which tells that these are the generated images. So that could be the reason why the accuracy is like that. But then yes, I mean almost 45% of the whatever, I mean the opinion of the expert, it says that those are the original images. The generated images they have claimed as the original one. That's how we have evaluated the performance. And then yeah, in terms of accuracy, whatever the model gives, that's calculating the error, basically the difference in the generated and the uh, real image. That's how we have evaluated the accuracy of this conversion. Basically it's with the help of the expert only. Okay, I'm just sharing my email address over here, so you can connect to me on my email. Okay. So yeah, is any other doubt or any question from an audience?
I think, ma'am, there is a question in the chat box. Um, Whether it is already answered or new
Yeah,
question,
yeah.
ma'am.
Regarding the
Correct.
accuracy, I have already
Yes, yes,
answered.
it's already answered. Only one question in the chat box. Yes, ma'am.
Yeah. So basically, I mean, this
Uh,
medical domain, I would only suggest like you need a lot of help of the medical experts or clinicians, because we work on the models, we know how to improve on accuracy, how to tweak it, how to pre-process, but then what they are interested in, what kind of features they want us to take out, what kind of additional information. It happens that they have the information, but they are not much sure that this will also help to improve on our accuracy. So we may have some kind of meetings like what else you have, what else you can provide us to add on the results, improve on the accuracy. Mm. Yes, Pramod, sir, you are saying something.
no, ma'am.
So yeah, I mean rather our model gives the result. Of course, we rely on the accuracy like evaluation. Typically, we do, uh, but then their opinion also matters. Like the expert opinion matters at each stage. As I said, that at the time of annotations as well. Like we had done the other work like. segmenting different kinds of micro uh, organs like vessels, micro vessels, and then goblet cells and villi, some micro elements which can be seen in the laboratory with the help of these microscope. But then the endoscopy, the advances are such that we can see all those details with the help of endoscopy. So, but then uh, we are not from that field, so we are not able to make the different kind of cells, what different kind of cells are there. So for us it we find it same and not able to differentiate. So such kind of thing we definitely we require the input from clinicians. Oh, can dental OPG it, I'm not sure, I haven't read, but then yeah, I mean if you have the corresponding images probably it can be, I'm not sure because I haven't seen the kind of images. So yeah, we can try doing, but there is the paper. I mean, I haven't come across. Rather, I haven't searched on that. Generative models. I mean, the generative model. The major concern is since it generates the synthetic data. The first question comes on the authenticity. That I mean, this is right. Who will say? Everybody afraid saying that yes, this is something, I mean some framework should be there. That's a major concern. The acceptance of that synthetic data is a major concern. For some other domains like just the photography and which is not that uh, life impacting, for such a thing one can trust. But then for this time, I mean life critical things, the reliance on synthetic data is still a question mark. Of course, I mean the protocols development are going on to how to consider it for what kind of processes and uh, to the correctness of that, evaluating some other ways. I mean other identifying some other ways to evaluate the correctness of this thing, generated data. But then acceptance as of now is really a challenge. Okay, so are there any question? So okay, if there is no
Participants,
other
if you don't
question.
have any doubts, participants, if you don't have
Okay,
any doubts, we'll wind up the session. And about the next session, I'll give you information in the chart. And meanwhile, you can fill the uh, reflection journal also.
okay, if yeah, if no other question, then or you can connect to me on this link. I mean I'll share my email address. If you have any doubt, you can send me a mail and I will respond on the same. Okay, thanks everyone. Thanks for joining. Thank you, sir,
Yes,
and
madam. Thank
thanks.
you. Thank you, madam. Thank you, Dr. Ujjwala Kiran Chaudhary, ma'am, for your insightful session on AI for biomedical images. Ma'am, you demonstrated how integrating expert evaluations with the AI generated images. Uh, your session helped us appreciate both the power and limitations of AI accuracy, reminding us that collaboration between the data scientists and clinicians is essential for advancing this medical imaging, ma'am. We are grateful for your practical guidance, openness, and expertise, which have enriched our outstanding and inspired. Um, to pursue effective, trustworthy AI solutions in this important field, ma'am. Thank you. Thank you so much.
Thank you, and thanks to the organization for giving me this opportunity to share my experiences. Thanks, everyone. Thanks a lot. May I leave the session, sir? No?
Yes, ma'am.
Okay. Thank you. Thanks.